All right, good morning. As you may have noticed, we're running a little bit behind, so we are just going to jump right in here and get going very quickly. So when it comes to rebuilding the human body, we've talked about the use of mesenchymal cells as one approach. Now we're going to take a look at other regenerative techniques, some actually very interesting regenerative techniques, such as growing skin, 3D printing to make organs, and ways to turn on quiescent stem cells and attract them to injured areas of the body. So first, please join me in welcoming Dr. David Ahrenholz, who's a former president of the American Burn Association. Where are you?
Right here. Good morning.
You're sitting right next to me. There you go. Next to that is Dr. Tony Atala, director of the Wake Forest Institute for Regenerative Medicine. He's also the W.H. Boyce Professor and Chair of the Department of Urology at Wake Forest University. Welcome, Tony.
Thank you.
Keith Murphy, the chairman and CEO of Organovo, a firm that designs and creates functional living human tissues through 3D bioprinting. And finally, Marc Penn, the director of research and cardiovascular medicine fellowship for the Summa Cardiovascular Institute, a nationally recognized heart care center. And we will begin with Keith Murphy. Keith?
Thanks, Max. I'm going to talk to you a little bit about Organovo.
Keith, I apologize,
okay.
And somebody's going to yell at me. We meant to run a video here first, and I will get yelled at later, but that's okay. I'm used to it. Can we run? We have a short video here that we call the skin gun, which is a very interesting use and approach to stem cells and repairing tissues. If we can run that, please.
Skin is the largest organ in the body. And when it's severely burned, it needs to be replaced quickly and massively.
The standard techniques that we have now, that takes weeks, months, sometimes. And the reason why people die is because of the infections that develop while we're waiting for the skin to heal.
How are you doing pain-wise?
Pretty good.
Okay.
So if we could find a way to get normal, healthy skin, as much of it as we want, within a week, that's the holy grail in burn surgery.
George Gerlach thinks he's found a way, but he'll need a gun.
We call it a skin cell gun, a device for the deposition of skin cells onto the wound.
It looked like something you'd see in Star Wars.
This is Matt Urum, state police officer from Pennsylvania. Skin.
Now, Keith.
Thank you. All right, so I'll talk to you a little bit about bioprinting. So Organovo is a premier bioprinting company. We're based in San Diego, California. We're a public company, so please observe the safe harbor statement here. But to orient you on who we are, we were founded in 2007. About 100 employees at this point. We are public. We've been public for about 4 years and raised about $140 million towards the research and development that we're doing in 3D printing. And we've generated major partnerships over time. I'll talk to you a little bit about those, but Merck, L'Oreal, and Astellas, and with Astellas and Bristol Myers Squibb as major customers of ours, and we've become known in the space as a premier company. We got a number of accolades over the years, as you can see on the slide here, including last year being a technology pioneer with the World Economic Forum. So we were invited and participated at Davos last year, which was very nice. So a strong record and a track record in the research and development that we've been doing. And I'll tell you a little bit about what we do. So we don't have time, unfortunately, to go into the details, the technical details of what bioprinting is. But in short, it is the creation of a living tissue, starting with cells as an ink. So we take those cells and we build what we call a bioink. We layer the cells in 3 dimensions, and we can build architecture within the tissues and get to a functional living human tissue. And as you can see on this slide, there are a number of tissues that we build quite successfully. And what you notice importantly is that these tissues look like native tissues. So they have a cellular density like the native tissue, and that's important. We don't use any biomaterials inside that, and we get to a very strong reproduction of the native biology. We use that in the ways you see here on the slide, with an early goal in transforming the way research is done using these tissues and displacing animal models, and the end goal of taking these tissues and transplanting them to patients working through the normal process in clinical trials to get them to impact patient lives. So I'll tell you a little bit about the depth that we've worked in, and liver is the tissue that's most advanced, and there's a really strong unmet need in liver because liver cells on a dish simply don't perform like the native human liver. And so there's a strong history of known challenges in trying to solve liver disease, partially for this reason. There simply aren't good animal models that can be built. In addition, safety prediction with the liver is very poor. You'll hear stories all the time of a pharma company that takes a drug forward and has a surprise in phase 3 studies because the drug ends up being toxic to the liver. That's because they rely on animal models today and they rely on cells in a dish, which simply can't be very predictive. So what we're doing with this liver is we've built a really strong 3-dimensional liver made of multiple cell types with complex architecture, and we've demonstrated over time that it functions very closely to the native human liver. So the most recent and the cutting edge data on that I'm showing you here, and this is an opportunity to impact disease, and in particular a disease that is very challenging because pharma can't find good drugs for this disease, liver fibrosis, which can be in a number of forms, including NASH, which is known as fatty liver disease. There's no good animal models for this. There are some animal models that exist, but large pharma companies typically don't trust them. They don't take drugs forward with them. So what we've built here is really the world's first model in a dish usable for research for liver fibrosis. What this chart shows and what the graphs show you here is the exposure of our native liver, our 3-dimensional bioprinted liver, to methotrexate, which is a known commonly used drug, especially in rheumatoid arthritis, but it causes liver fibrosis in a strong number of patients, a large number of patients that are on it chronically. And you can see from the graphs here, or from the histology, or the slides, that we actually can slice these tissues and look at them under the microscope like you do with native tissue, that what we've shown is we match the native pattern of this disease forming in these tissues, which is really powerful. So pharma scientists, doctors who work in this space get very excited when they see this data because there's been nothing like this before. And we even match the biology of this to the extent that if you look at this chart which shows when this liver, our liver in a dish, actually starts to show some of the blood markers that you would see of loss of function, you don't see that until day 14. Twice as long, it takes twice as long to get that loss or that demonstrated biochemical signal versus the fibrosis which forms in the liver at day 7. That matches how this disease emerges in patients. It's diagnosed by biopsy because you don't see liver biomarkers actually showing this disease early on. So we're matching it very closely. We work in a number of other tissues as well. I'll just give you a brief overview of those. Kidney is the next tissue for us. We are commercial in using the liver for preclinical safety prediction with pharma companies, and kidney will be next. But kidney is an important one to get into the regenerative cures as well. We want to make kidney tissue available for transplant for patients over time. And one aspect, it's a little bit technical, of bioprinting is that we can't print at the resolution of all features in a tissue. We just can't go that small. If you think about the kidney, it's got the finest features of all, almost glomeruli and nephrons. We can't print at that level, and the cells actually shape in 3D themselves to make some of that tissue. So we pursue avenues to have the cells themselves do that work, almost like they do in the human embryo. So we partner with academics to do this. This is work that was from the lab of Melissa Little and the University of Queensland in Australia. We sponsored this work. She had shown early promise in getting to some of these kidney tissues, early kidney architecture with embryonic stem cells in an earlier publication, and we asked her to take that work and change it to induced pluripotent stem cells, which you've heard about during the course of this conference. A much more amenable way, we feel, to treat patients and take a product to patients long term. And she had a home run. This was published in Nature, where you see the complex kidney architecture being formed. You can see from these images. And she demonstrated kidney toxicity could be seen in these as well, where you see the cisplatin actually causing kidney damage. So these are really powerful applications for kidney. We're also working in bioprinting skin. We have a partnership with L'Oreal to build the world's first full-thickness skin. What you can see here is epidermal skin, which is the top layer of skin, which we're building successfully already, and we're on the path to full-thickness skin. This can be used in any number of ways. Again, you can think about taking this back to patients, treating for burns and things like that, and we'll hear more about the current state of burns in a moment. This is the Organovo team. I have to thank them. Of course, everything we do comes down to people and patients, and you've heard so many great patient stories during the conference. It's very rewarding to work in life science. There is a gentleman on this slide who's had to leave Organovo due to his cancer, and one of the proudest moments of my career is that I worked on a drug at Amgen for 4 years. I was a leader in the product strategy of that drug that has helped him tremendously. And these are the kind of impacts we can have in this field, and it's really what motivates us. To that end, I wanted to note, too, an effort that I'm working on in a nonprofit setting. So I'm CEO of Organovo, but I also work as chairman of the Human Organ Project. And we are a nonprofit foundation motivated by building additional resources for scientists in this space, this goal of getting to full thickness or full organ regeneration. Teams like Tony Atala's at Wake Forest, funding them greater with philanthropic grants. So we actively solicit philanthropic grants and provide grant mechanisms for these researchers. We do that through the American Society of Transplantation, where they'll do the grant reviews and score those for us, and we pass the monies on to these great scientists. So very active in that and growing that as well. I think there's a strong roadmap to how we can have these breakthroughs that we're trying to establish and move forward on.
Very good. Thank you, Keith. And now, as you mentioned, someone else who has a lot of experience with 3D printing is Dr. Anthony Atala. Tony.
Thank you, Max. It's great to be with all of you today. And what I thought I would do today is really give you an overview of some of the work that we're doing at the Institute for Regenerative Medicine at Wake Forest. We have about 450 people at the Institute all working together to bring these technologies from the bench to the bedside. This is actually part of our strategy that we use, where we actually use either cells alone or cells and scaffolds together. So we've brought several cell-only therapies to patients. The most recent one, for example, is we take a biopsy from a kidney from the patient with end-stage failure. We expand the cells outside the body. We then use hydrogels to inject these cells back into the kidney. This is now completed phase 1 clinical trials. We are 2 years out with this therapy, showing maintenance of the therapy for the 2 years. We're starting now phase 2 clinical trials in 5 centers throughout the U.S. This is a technology that we developed that we have now moved on to the clinic. Another therapy that we use, one of the other clusters of therapies that we use, are basically cells and scaffolds together. And in this strategy, what we do is we use cells and scaffolds to replace structural defects. For example, in this slide that you see here, you see a patient who presented with a motor vehicle accident. And you can see here the large gap in the urethra. This is the channel that connects the bladder to the outside of the body. And you can see here this large gap between the top portion of the bladder and the bottom. So now we had to replace this, so what we ended up doing is we followed our strategy, which is basically to take a small piece of tissue from the patient, less than half the size of a postage stamp. We expand the cells outside the body. Within 30 days, we have enough cells for our construct. We then take a scaffold, which is tubularized. We coat the outside with the muscle cells, the inside with the urethral lining cells, place in a bioreactor, and place it back into the patient. This shows on the left the X-ray of the patient. In the second panel, you see the scaffold alone. In the panel on the right, you see the scaffold and the cells seated on the scaffold prior to implantation. We implant these surgically, and here you see the X-rays of these patients. On the left, you see the defect. On the middle panel, you see the engineered urethra. And we published that paper in The Lancet back in 2011. When we published the paper, we had basically almost a 6-year follow-up in our patients. Another structure that we have also engineered are tubular structures such as blood vessels. Same strategy here. This is actually a carotid artery that you see that we have implanted here on the right, showing patency that we published in the journal Nature Medicine, and of course many clinical trials in this area. Another strategy that we have used is actually to use these bioreactors that we developed many years ago. This is, for example, for a heart valve. Now, we have not implanted these in patients yet, but it shows how the bioreactor is actually working And you can see here the heart valve leaflets opening and closing to actually show the flow going through the structure to actually condition these structures before being implanted in vivo. Now, I've discussed with you some of the increasing difficulty on these tissues because flat structures like skin are definitely the least complex. Tubular structures are the second level of complexity. Hollow non-tubular organs are the third level of complexity, and the bladder is one such organ. Same strategy here. We take a small biopsy from the patient. We expand the cells outside the body. 30 days later, we have enough cells for our construct. Same strategy where we coat the inside cells, the urothelial cells on the inside of this three-dimensional scaffold, the muscle cells on the outside. We then place these in a bioreactor, and we are able then to place that back into the patient. We published our initial preclinical series in Nature Biotechnology back in 1998. And this is really what started our human clinical trials. These are basically patients with end-stage bladder disease who were treated with these engineered bladders, and we published that paper in The Lancet in 2006. When we published that paper, we had over a 5-year follow-up in those patients as well. Basically, this is an instance where we actually put in an organ where there was none present. This is a condition where the patients are born without a normal organ, but they do have a rudimentary structure. So what we do is we take a small biopsy of the rudimentary embryonic structure. We then grow and expand the cells outside the body, create the construct. On this MRI, which is an X-ray, on the right you see the rectum. In the middle panel, you see the paucity of the organ. On the left, you see the bladder. We implant basically the engineered organ, and you here now see the MRI with the new engineered organ in place. The rectum on the right, the bladder on the left, the new engineered organ in the center. Again, placing an organ that was not there previously. Then when we follow these patients basically for 8 years, we did yearly endoscopies, yearly biopsies, yearly MRIs, and yearly functional testing to show that these organs continue to work well long term. And again, we published a paper after we had a 5-year follow-up. In fact, in this particular study, we went all the way to 8 years before we published the results showing good, adequate function long term. So basically, what we like to do is to engineer these tissues by hand. About 14 years ago, we started looking at bioprinting. Can we actually scale up the technology? On the top panel on the left, you see that we started out with these basically desktop inkjet printers. And instead of using ink, we started using cells to create these two-dimensional structures like this two-chamber heart. But they didn't have the structural integrity necessary to be implanted inside the body. So over the last 10 years, we started to develop more sophisticated systems that have nozzles that give you a lot of precision. These nozzles go down to about 2 microns. That's about 1/80th the diameter of your human hair. And we're able then to print these scaffolds, and we print them in a way that actually creates microchannels, which allows for large constructs to be formed with these microchannels that create a highway really into the central portion of the tissue. And you see here that we published that work in Nature Biotechnology. So basically overall, we are working at the Institute in about 30 different tissues and organs. We've already transferred about 8 of these into patients. We are working now to transfer another dozen more. And really, I'd like to leave you now with one slide, one short video of a patient who was treated with one of these engineered organs 13 years ago. This is from an interview he gave 3 years ago to one of the media outlets.
I was really sick. I could barely get out of bed. I was missing school. It was just pretty much miserable. I couldn't, go out and play, basketball at recess without feeling like I was going to pass out when I got back inside. I felt so sick. I was facing basically a lifetime of dialysis, and I don't even like to think about what my life would be like if I was on that. So after the surgery, life got a lot better for me. I was able to do more things. I was able to wrestle in high school. I became the captain of the team, and that was great. I was able to be, the normal kid with my friends, and because they use my own cells to, build this bladder, it's going to be with me. I got it for life, so I'm all set.
That's Lucas Masella. He's now, as I mentioned, 13 years out from having received his engineered organ. As we know, there are many challenges still that remain ahead in the field: scalability, cost, and others. But one thing is certain, and that is that these technologies do have the potential to make patients' lives better.
Thank you, Tony. I think the interview I did with Luke actually was much better than that one. Yes, you heard the clicker. So David, it seems that a lot of people are talking about skin here and how to replace skin, particularly after burns. So talk to us about burns.
Okay, so I'm going to tell you in the next 5 minutes what it normally takes me 9.5 minutes, and that is everything you need to know about burns. So I'm going to talk about engineered skin substitutes, which are a solution for a lethal injury today. Now, we live in a very dangerous world. If you look at the news, you will recognize that there are accidents around the world. These are in the last 12 months where there were hundreds of people injured in accidental explosions. This is also true with terrorist events. But worldwide, the daily risk of burn injury is highest for women and children, especially in countries where open flames are used for cooking, illumination, and heat in the home. No one is immune. There is no vaccine. No matter how good your genome is, you can be affected tomorrow or next week by burns. Even in the United States, 875,000 people are injured every year. 45,000 are hospitalized. Worldwide, 11 million people will seek medical care for burns this year. Next year, it'll be another 11 million. Most of these burns, as shown on the left, are superficial and can heal without the need for a surgeon. However, when all levels of the skin are destroyed, called a third-degree burn, it's my job as a surgeon to remove that dead skin, which becomes very quickly infected, and then replace the functions of the skin that have been disrupted by that burn. We have two layers to our skin, the outer epidermis. It blisters easily with friction or heat injury. That makes a blister. It acts as the barrier to keep our body fluids inside so we don't die of dehydration, and it keeps bacteria out of us from killing us by invading our body. It regenerates easily from sites that reside deeper in the dermis. The deeper layer is called the dermis. It's very durable. It's stretchy. Its function is to nourish the renewable epidermis, and with the underlying soft tissue gives our bodies their more or less attractive contours, some of which actually are very attractive, but not shown here. So in the best possible case, a patient has a very small third-degree burn, undergoes a one-stage procedure where we take a layer of epidermis and a portion of the outer dermis, shown at that dotted orange line, as a split-thickness skin graft from a donor site, which is at the bottom of that picture, and move it to the burn site as a sheet of skin. That gives a fairly good cosmetic outcome, and that's always our goal. However, and this patient is about a week out after a burn, about 5 days after injury. For larger burns, we have to actually take that skin and we run it through a mesher. And that pattern is permanent. Every time I show this slide, I cringe. That pattern is permanent. Even worse, when we have to use the same donor site over and over. The donor sites can look as bad as this. Imagine your child looking like this. Sorry, it's pretty close to my heart. So, with massive burns, patients are hospitalized for months as the donor sites heal and are reused. The patients experience constant pain, recurrent infections, and severe scars. Many patients die before the wounds are completely skin grafted. Since 1991, commercially it has been possible to grow epidermis in culture and to treat massive burns where the donor sites are inadequate, but it has many limitations. Only the patient's own epidermis is currently used because the epidermis is so antigenic. It's fragile, it cannot be meshed to cover large areas, it's easily lost to early infection. In the absence of dermis, it never becomes durable. This was my first experience with cultured epidermis, and this is back in 1985, 30 years ago, or 1986. And it was an incredible disappointment, and it still is. My patients hate their epidermal grafts because it acts like butterfly disease. It doesn't get durable. Stephen Boyce and his team at Cincinnati Shriners Burn Center have developed a method to co-culture each patient's epidermis with a layer of living fibroblasts, which make collagen similar to the proteins in our dermis. The resulting unique grafts are markedly different from cultured epidermal grafts. They are durable and less likely to be lost to infection. They can be meshed, and the grafts grow as the patients grow, even for children. We have children now that were grafted 16 years ago, and their grafts have grown. The technology, however, has never been available outside of physician-sponsored protocols at the University Research Facility, and I had to send my children from Minnesota to Cincinnati to get this product. I'm not going to go through the details of how this is produced. Suffice it to say that you excise a piece of skin and close the wound. You take it to the lab and you separate the cells, which then are grown on a biopolymer scaffold. After about a month, we have multiple pieces of skin which can be transplanted then onto the areas of burn. And not only do these pieces of cultured skin look like a split thickness skin graft histologically, but they can be grown in very large sheets. And the result is that these children that have been treated have had remarkably good outcomes. Here is a compassionate use trial of 16 children entered into a study. Mean age 6 years, mean burn size 78%, expected mortality greater than 35%. 15 of the 16 children lived long enough to get the grafts and all survived. Here's one of those children. You can see the white squares where the cultured epidermis and dermis, the construct, bilaminar construct, has been applied to the back. The red raw area is the area which is about to be grafted with the patient's own skin using the remaining donor site. And this is the appearance 1 month later. That's remarkable. For the first time, this ESS is being grown in a GMP certified facility in Maryland and will be used in adult patients in a clinical trial at the Brooke Army Burn Center in San Antonio. Additional patients will be enrolled at burn centers in Seattle and Phoenix. If the FDA accepts these data as pivotal, this technology will be available in the US with plans to expand to European and Asian markets. So, in summary, burns can affect any of us or our family members tomorrow or a month from tomorrow. ESS technology has been used successfully in severely burned children, and it's my belief that when the next conference is going to be in several years from now, someone like me will stand up and explain that the mortality of burns in patients who would get to burn centers alive has dropped by 50%. Thank you.
Thank you, David. I think you can see that the work that we're presenting up here is more than just science for our researchers. It's a passion and it's their life. Thank you. Marc?
Thank you, Max.
Marc?
So I'm going to talk to you about our work on understanding the activation of our own stem cells that exist in all of our bodies to try and repair tissue. We started this work well over a decade ago, proposing a hypothesis that's before you. Stem cell-based repair of ischemic tissue in mammals is a natural process but clinically inefficient due to dysregulation or short-term expression of key molecules. Said differently, we as mammals have evolved to scar instead of heal, we believe, in an attempt to minimize tumor. And we sought to understand where these dysregulations occurred because we believed we could induce the body to heal itself through either drug or gene therapy without the need to actually give the body cells. We originally made the observation that if you put stem cells in the bloodstream of an animal having a heart attack, those stem cells show up in the heart. But if you put those stem cells in an animal that has heart failure, they don't. So something's released by newly injured tissue that tells the body, I've been injured, come help me, and tries to recruit the stem cells. We sought to identify that molecule, and in 2003 identified stromal cell-derived factor 1, or SDF1. What we've learned is that in nature, if someone has a heart attack, the key molecule for the recruitment of stem cells to the site of tissue injury is up and down within 5 days. However, we've learned that if you can express this molecule for 2 to 3 weeks, it is sufficient to recruit a sufficient number of stem cells to the site of tissue injury so that we get 4 things. Recruitment of bone marrow stem cells that grow a microvascular network, small blood vessels. Activation and recruitment of tissue-specific stem cells. So in the heart, it's cardiac stem cells. In the liver, it's liver stem cells. In the brain, it's neurostem cells. And these stem cells go on to do what they're destined to do. It prevents the formation or remodels existing scar, and it inhibits cell death or expansion of the heart attack infarct or the penumbrum in stroke. And we ultimately demonstrated that adult stem cells, particularly the mesenchymal stem cells like you heard about in the session before, actually work in part through the release of SDF1 into the tissue. And the blot shown in the lower right here demonstrates that at baseline, the heart expresses no SDF1. At an hour after a heart attack, it does. A day after, it does. But within 7 days of the heart attack, again, the key molecule for telling our body that we've been injured and to recruit stem cells is actually gone. We've now we developed a drug, a gene therapy, a plasmid DNA that encodes human SDF1. We delivered it in a randomized double-blind placebo-controlled trial to patients with severe heart failure and followed them up at 4 and 12 months later. Now, I'll remind you, we took these patients to the cath lab, injected their heart, and the drug expressed for 20 days. Yet at 4 months and then 12 months later, we saw continued benefit in improved ejection fraction, or the squeeze of the heart, where we improved it in patients who'd received the high dose of about 6%. The placebos with severe heart failure continued to get worse, leading to a clinically meaningful, statistically significant improvement in ejection fraction. We've also looked at this in skin healing. This, the back of a red Duroc pig who develops hyperplastic keloid-like scars when you incise their full-thickness skin and close the wound. In the animal on the top, they received glucose injection, the carrier for the gene therapy, and on the bottom you see the overexpression of SDF1 for 21 days leads to a much improved cosmetic result. We followed this up in a phase 1 study in patients undergoing sternotomy for their first open heart surgery. We dosed the patients at the end of surgery in multiple doses in a single treatment time immediately, again, post-surgery. You'll see that the wound width at 21 days in the placebo actually increased from the immediately post-surgery, yet with each treatment of SDF1, those patients had significantly reduced area of wound at 21 days. This led 6 months later to an improvement in cosmesis, so the cosmetic outcome, with a dose-dependent decrease in the patient observer scar assessment scale, or the post-test scale, both from the physician and the patient point of view, and this too was a double-blind randomized placebo-controlled trial. We've also studied this in critical limb ischemia and found significant improvement in wound healing in this population, as well as a reduction in pain, and that clinical trial, additional clinical trial, is ongoing. So basically, we've been able to take a complex cell therapy process of harvest, cell selection, and/or propagation, and we believe that by activating the endogenous stem cell system in each of us, we can significantly enhance our body's ability to repair using a system that we fundamentally have downregulated. Again, we believe to minimize tumor, and it is worth noting, going back to our original hypothesis, that virtually every tumor in our body makes SDF1, so you can envision why we would have downregulated this system long ago. Thank you.
Thank you, Marc. So now we only have a few minutes, so I ask you to make keep your answers very, very brief and short. But Marc, as long as we've been talking here, how is the SDF administered?
So it's a direct needle injection.
Into
the organ of interest, so the leg for critical limb ischemia, the skin for wound healing, and the heart for heart failure.
So now, can SDF1 recruit these cells to the repairing cells from distant sites, and how are they, you said it puts it out, so that can be like a general alarm. Do they follow a concentration gradient then to get to the actual site of injury?
That's exactly right. The nice part about the system, there's a smartness to it. If you inject the heart, the cardiac stem cells get activated. The liver and the brain don't care because they don't see the signal. And then as we all release about 30,000 stem cells a day from our bone marrow, so we're recruiting those cells as they go through the heart.
And is there a role in terms of cancer to prevent the tumor from using this?
There are those that are looking at inhibitors to SDF1's receptor, CXCR4, as an anti-cancer therapy, yes.
Interesting. David, tell me about, you told me that this bilayer, cultured epidermis has actually been around for a decade and a half.
That's correct.
We've got a lot of burn patients who need this. Why hasn't that gotten any further?
Well, it could only happen in America that the company that bought the rights to produce the product was acquired by another company, which then decided not to produce the product. And the resulting lawsuits meant that for the last 6 years, nobody in the world has had access to this technology.
But it is
So a white knight, Amaranthus Corporation, came in, bought the lawsuit, and we will go forward.
Is this something that is going to be economically viable in so many other countries, obviously, where, as you mentioned, we have many, many burns?
Well, for third world countries and countries that have low incomes, we have to start at the beginning. And in a third world country where you don't have access to medical care, a 10% third-degree burn is lethal. In the United States, if you have a third-degree burn, 10% of your body, it's one operation and 7 days in the hospital. So we need to get past that hurdle. But in countries that have high incomes, this is going to be a huge cost saving because an 80% burn patient will stay 6 or 8 months in the hospital at a cost of $10,000 plus per day, and you can shorten their hospital stays by 3 or 4 months by using this technology, not just saving their lives.
Cost effective, clearly.
Yes.
Tony, you said you put in kidney cells into the kidney. Do they then sort of self-organize?
That's right. So basically what you're doing, with any type of organ failure, what you're really looking at is scar. That's the main component. Regardless of the organ that you're dealing with, if it has end-stage failure, there's one common denominator, regardless of what causes the disease, and that is scar tissue. It's not that the cells within the organ are not reproducing, because they are. It's just that they don't have the space into which they can reproduce. And so basically, technology is really dual in the fact that you want to inject the patient's own cells back in, but also create a space for those new cells to actually have the room to grow and create new tissue.
And then they organize into functional nephrons?
That's right, and that's what that slide showed. It actually showed all those new nephron units which had been regenerated. And then these patients basically, in the phase 1 clinical trial, these are patients who had end-stage renal disease, and they were progressing in a downward direction, and basically showing that they stopped having that downward progression with just one treatment.
You said you use tissue-specific cells. Tell me about what's the advantage to using the patient's own cells versus some of the other strategies that we've been hearing about?
Yeah, we actually use all cells at our institute. So we use iPS cells, we use bone marrow stem cells, cord, et cetera. But there is basically an advantage to using your own cells, the differentiated cells, because basically when you get those cells from the tissue-specific area, you're getting cells that already know that that's what they're going to do. So when you get a muscle cell, that muscle cell already knows it's a muscle cell. When you inject them back into the body, unlike other stem cells, as you know, other stem cell treatments, basically you inject the cells and they're gone. You can't really track them. They may incorporate, but at very, very low levels. When you inject the patient's own cells, they basically stay behind because that's where they belong. So they actually incorporate into the tissue. And also, the third advantage, of course, is that it's really black and white. You can see when we replace these structures with the tissue, the structure is really either there or it isn't. It either works or it doesn't. So it's pretty much black and white. So you can have a good way to track these cells long term and know that they're in place.
And just quickly, because we've only got a couple of minutes, and I do want to make sure that Keith gets a shot here. When you take that biopsy and you said you grow it in the dishes, do you separate out the endothelium, the inner lining from the muscle layers and culture them separately, or turn them all loose?
Exactly. We actually separate, it depends on the organ actually, what the strategy is, but typically if it's a structure that we need to layer, we do expand those cells separately and then put them back together. If it's a 3D organ, we basically want them all to be together.
Interesting. Keith, you're printing organs here, and I think the question that everybody is thinking is, when are you going to, print that liver that I can have my liver replaced so I can keep drinking for a while?
Yeah, it's a good question, and it'll take time to get there. We do work on things like bioprinted liver tissues for transplant. We tend to think of it on how we can impact patients the fastest, and there are challenges in the field in terms of building a full organ, but we can build things of a certain size already. So we're advancing tissues rather than full organs and looking towards a time 4 years perhaps from now where we'd be in clinical trials with a liver patch, which can dramatically impact patients, because if you think about the waiting lists that exist today, there are folks who can use a liver patch, something that's 10 to 15% function, but can bridge them for another year before they get a transplant, because by the time they need a transplant, that's about how much liver function they have left, 10 to 15%. You can also impact a number of patients almost equal to the waiting list, because there are patients who can't get on the waiting list. If you're elderly or you have another disease that doesn't make you a good candidate for a healthy liver, you're not going to get on that list. But those patients still need solutions, and we can potentially treat those with a patch as well.
Oh, that's really interesting. Now tell me, and I think you alluded to this, but let's make sure that we're clear on it. Being able to create some of these very small organoids, I guess for lack of a better term, actually is still very, very useful in terms of ultimate patient impact. How so?
Well, I think if you're looking towards that larger goal of eventually getting to patients with full organs, you have to think about, since that is a longer time, how can you impact patients sooner? And we said, let's start, our strategy, rather than build the whole organ at once, has been to perfect the biology of the organ in question at the smallest possible scale, and then build up from there. So having worked on that and coming very close now with liver to having nearly perfect liver biology reproduced, we've actually built a business around that, where we'll actually use that in drug testing. So I showed the liver fibrosis model earlier. That's a powerful aspect of it. But just think about the potential in tox testing, where a number of drugs are taken forward and fail. If anyone's seen the film The Constant Gardener, that was about a drug that was taken forward and used in patients. By the time it got marketed, it caused acute liver failure in hundreds of patients, and many patients died because they didn't detect the toxicity of that drug until it got in hundreds of thousands of patients. We took that drug and put it into our liver tissue, and were able to show in 7 days that it was toxic. No drug company would have taken that forward with the tools we have today. That's the kind of power you get. You can bring drugs to market that are going to be safer. You can get them to patients sooner. Alzheimer's has been hung up on challenges with the liver toxicity of the drugs. RNAi, which folks in the space will understand is another technology that can be quite powerful, is hung up because of liver toxicity impact. We can hopefully unlock some of those technologies and move things forward in a way to get them to patients faster.
And finally, very quickly, can you help David out here in making skin?
We talked about that in the prep room. We're very excited about that, and again, we're following a stepwise progression. So if you look at what we're doing, we're partnered with L'Oreal building 3D skin. There's a first level use of that. Animal testing is now outlawed, properly so, in Europe for any cosmetics. They don't have good ways to develop new cosmetic agents. That's a direct use we can use, and the funding from L'Oreal builds 3D skin that we're building for that testing purpose. And then we have something that we can take forward, use that as a step towards getting to full thickness skin that can impact these patients. And I think versus the things that are available today, and David talked about some of the challenges with those, full thickness has the ability to be vascularized, which can provide a better graft over time, which actually has blood vessels in it and can be engraft better and have fewer scarring, or less scarring.
Help him out, please. Thank you, panelists. Really interesting. I mean, we've got some really cool stuff going on here.